Hello, I'm Peter Tawil, and today I'll be presenting to you a case on the management of congenitally missing lateral incisors in the maxilla, mainly focusing on the surgical part. It's a very challenging case that we completed in our clinic, and let's jump in directly to the case. Upon clinical analysis, this is after orthodontic treatment. The patient is a 17-year-old young female with obviously two missing laterals in the maxilla, missing laterals, congenitally missing, so obviously no bone at all. So after radiological analysis and cone beam CT, we verified the diagnosis of missing alveolar bone, and therefore she needed a autogenous bone graft to augment the site, both sides, in order to create the proper bone width to withstand an implant in the future. So this is looking in the case. We have obviously, as you can see here in the picture, a substantial amount of bone loss and even unpresent bone. We decided in that case to go for the autogenous bone graft taken from the retro-molar area. In the same time, extract her third molars, impacted third molars. Now, the little twist in that case was the choice of the technique used in the recipient site. What we did was a tunneling technique, meaning we only incised vertically distal to the site that was going to receive the bone graft. Obviously, a full thickness flap was done, but just one incision. And you can clearly see here also that on the occlusal part, we have no incisions, meaning that we're trying to contain as much as possible the blood vessels and preserve the integrity of the flap to enhance bone healing. Going back to the donor site, we extracted the impacted third molar, just a regular surgical extraction, and went on with harvesting the block graft from the retro-molar area. It's about 20 millimeters by 2 millimeters thickness. The advantage of this technique is that you can do two surgeries in one, meaning extracting the third molar and in the same time harvesting the autogenous bone graft. The graft was later stabilized with two screws on the recipient site, and flaps were sutured. As you see, a very atraumatic way of doing it. Now this is the X-ray post, a bit elongated, but the X-ray is clearly showing the two screws in place. You can also appreciate the fact that the space in between centers and canines is very restricted. We're talking 5 millimeters here, and that's the best that the orthodontist could do. Moving on to the other side, we used the same technique where we drew an incision on the distal part of the deformity and raised a full thickness flap, preserving the occlusal part of the flap and the integrity of the flap, and doing what we call the tunneling technique. Same harvesting technique, extraction of the contralateral impacted wisdom tooth or third molar, and then harvesting of the retromolar in the retromolar area of the autogenous bone block, stabilization of the block, with 2 screws, suturing, and this is the X-ray post-operative. Flaps were allowed to heal properly, and 5 months post-operatively, you can clearly see the screws almost showing up from the gum, from the gingival tissue. This is to tell you how thin these tissues were. About 5 months post-operatively, we decided to go in again and place the implants. The patient was now 18 years old. Obviously, the distance between the central and the canine, and especially the dipping of the roots, was of a challenge here. And you can see a mark on the bone. This is to indicate our direction, just to help us not to drill into a root. This is a indelible um, marking pen. It is sterile. And during the implant placement, a clear radiograph should be taken during the drilling, after the drilling, at last drill, and an implant placement. You can see the place and the space in between was very, very restricted, but we were able to manage to place and squeeze in these 2 implants. These are 2 narrow platform Nobel BioCare implants. And one is a regular select implant with a trilobe connection. Another one is a conical connection. This was part of the trial and comparative study comparing 2 macrogeometries in the same type of situations. Challenging case, yet again, we're able to pull it out. It was the 2 implants were placed in a 3-dimensional space, inadequate 3-dimensional space. Obviously, the emergence has to be into the cingulum of the tooth, and flap was then sutured. Coming to the prosthetic phase, we decided to go with 2 screw retained crowns. Obviously, as you can see, the implant emergence is in the palatal or in the cingulum area, and this is the final result. Obviously, a very nice result. The patient was thrilled and happy to have her smile back. No gingival grafting or connective tissue grafting was done here. The matching of the pink and white aesthetic scores is very up high and very good. The patient was very, very satisfied. Yet again, we saw her a year later with a beautiful stability of bone and soft tissue contours and the ceramic and integration into the rest of the smile. And a great color match. Well, with this great result, I leave you all, and I thank you all for your attention.